So today I'm going to be talking about the era of P4 medicine in the challenges for endocrine surgery. Now, what we have seen over the last few decades is significant advances in the field of surgery and medicine. And to keep up with the pace is quite challenging for us as clinicians. There's a paradigm shift in the way we have been practicing medicine from clinical based to now it's becoming more technology based. And along with these changes, changing practices in medicine, the expectations of patients have also changed. Therefore, is it not the time to change how we learn and practice? And is it not the time to change how we teach our students and postgraduates? So it is challenging times for all the stakeholders involved in the care of patients, not just clinicians, but other organizations as well. If one looks back into the history of ancient surgery, we know how it was crude, significant complications, and mortality was high. And the reasons for these poor outcomes of surgery were increased rate of infections, bleeding, and poor analgesia. And actually addressing these three issues, analgesia in the form of anesthesia, and good controlled hemostasis, and principles of antisepsis, improved outcomes for a lot of surgical patients, especially in the 19th and the 20th century. Now, if you look at the progress of endocrine surgery over the last century or so, you would see, like I mentioned, anesthesia and refinement of surgical techniques, along with development of instruments like hemostats, changed outcomes for thyroid surgery. Now, Theodore Cocker, considered as the father of thyroid surgery, he had some excellent results with his thyroid surgery and was awarded the Nobel Prize in Medicine for his contribution to thyroid surgery. But the problem was that he was so disillusioned with the outcomes of patients who underwent total thyroidectomy because there was no replacement thyroxine at that point in time. It was only until 1914 that thyroxine was discovered, and it changed how we manage our patients post-thyroidectomy. In the 1950s, radioimmunoassays came into practice, and this helped us diagnose biochemically many of the conditions that we treat in our clinics today. In the 60s and 70s, we see the arrival of imaging in the form of ultrasound scan and CT, and then came along MR, SPECT, PET scans, etc., which is now in routine use for management of patients, especially with cancer. Since the 80s, we've seen the development of laparoscopic surgery and robotic surgery, and this has again has had immense benefit to the patients in the form of reduced pain, early ambulation, and morbidities associated with big scars like we used to do, decades ago. But this 21st century is the era of genomics and precision medicine. Now, there's a lot of technology that is coming into our healthcare practice. I mentioned about robotics. Now, things like wearable technology, like Google Eyes and HoloLens that are in practice. Of course, we know about computer vision in predicting diagnosis, etc. But the two things that are radically going to change how we practice medicine are artificial intelligence and genomics. So if you reflect back and look at how we used to treat and manage our patients, a lot of it was based on intuition. A lot of it was based on our own personal experiences in patients and their diseases. And the way we diagnosed this were based on symptoms and signs. But now we practice more along the lines of evidence-based medicine, based on data accrued from multiple clinical trials and prospective studies. And certainly these have helped improve patient outcomes as well. But the way forward is precision medicine, and that is radically going to be significant, it's going to play a significant role in how we manage our patients. So personalized medicine is a form of medicine that uses information about a person's genes, proteins, environment to prevent, diagnosis, and treat disease. Now, I just looked at the publications in PubMed just yesterday on articles relating to precision medicine. And you can see over the last 2 decades, there has been a 20 to 40-fold increase in publication. That just shows the amount of new knowledge that is emerging. And how it is important is that there's going to be a big paradigm shift in how we treat our patients. In the past, we used to treat all patients the same. Patient with a small PTC or a large PTC, they all had total thyroidectomy and radioiodine ablation. Now, we do know that now radioiodine ablation is not given for patients with low-risk disease because there is no benefit. So then came along stratified medicine, where we looked at risk profiles. We looked at biomarkers to identify patients at increased risk and then treat them more aggressively. But the way forward is precision medicine, where we are just not combining the clinical information, but also the diagnostic biomarkers and genomic data to manage each patient individually for their condition that they are faced with. Now, what is P4 medicine? P4 medicine is predictive, preventive, personalized, and participatory. Predictive is where we are assessing the risk factors, both intrinsic and extrinsic. And artificial intelligence is coming some way in helping us with this. Preventive is where the strategies on risk reduction. We know about the BRCA genes, especially in young patients with breast cancer on the MEN2A and 2B, where we can offer preventive prophylactic surgery before the disease actually manifests. Personalized is where interventions are based on specific risk profile. Now, we know in endocrine disease, certainly cancer, thyroid cancers, which express certain oncogenes such as BRAF and TERT, where they are associated with a higher risk of dedifferentiation. And when these patients present with recurrent persistent disease, one can offer targeted therapy based on the gene expression. Now, participatory is where we involve patients in every decision that we make for the patients. And this is something new, and this is something that has to be incorporated into our clinical practice. Now, what has changed in endocrine surgery is that there's a lot of information in relation to genetics. A lot of conditions that we see in our day-to-day practice, including that for parathyroid disease or pheoparagangliomas, thyroid cancer, neuroendocrine tumors, as a good proportion of these conditions have underlying genetic cause. And this makes it more important that personalized medicine should be practiced for better care and outcomes of the patients. Now, understanding the genetics has also helped us learn how thyroid cancers develop and progress from a well-differentiated to a poorly differentiated, involving the various oncogenes and tumor suppressor genes. And understanding these pathways has led to the development of various markers as well as various agents targeted against these specific pathways. And these are something like the tyrosine kinase inhibitors that we know are commonly used in patients with medullary thyroid cancer, or angiogenesis inhibiting factors that are in clinical trials at the moment. In parathyroid disease, we know how parathyroid cancers develop, and there have been studies which have looked at the various oncogenes that have a role in the promotion of this cancer, especially metastasis. And again, anti-angiogenic factors, have been introduced into not into clinical practice, they're in clinical trials at the moment, but it's not far away from clinical practice. Now, we do know about pheoparagangliomas. A significant proportion of these have inherited disease, and based on the mutations, one can predict the behavior, the sites where these tumors are likely to be, what is the risk of malignancy, and also help in not only just surveillance, but also provide targeted therapies for patients with locally advanced disease. So what is the impact of this personalized medicine? For the physician, for us, what it means is that we have a greater ability to predict the nature of the disease. We can use preventive strategies to help manage the condition, offer diagnostic testing and treatments tailored for that. But for the patients, their perceptions are different. They would prefer more a personalized care rather than use of technology. And they prefer a more holistic approach. That means not just treat the underlying condition, but also consider the physical, mental, and spiritual well-being. So it's important to note that it's not what you want to do for the patient, but what the patient needs from you. So it's when the wants and the needs match, that's when the patients have the best outcomes. Now, put into this religion does play a significant role, especially in a country like India, and these have significant connotations, which I will come to in a minute. So when it comes to implementing personalized medicine in endocrine surgery, there are quite a lot of challenges. The most important thing is the psychological aspect. And we have a lot of data from management of breast cancer in terms of what the impacts are. So in a survey that was done in patients with breast cancer, when they were asked, would they consider genetic testing, 60 to 75% did say yes, they would, if it helped in the management of the condition. But when they were diagnosed with cancer, only a small proportion chose to have a genetic testing. So this is quite interesting. Now, the other problem is that where patients, where they could be offered preemptive testing and prophylactic surgery, patients did not take it up universally. There was a lot of resistance in taking that up. Even when a diagnosis of cancer was made in premenopausal women, about 20 to 30% refused genetic testing. And one thing it did was change behavior of these patients. They started avoiding clinics and surveillance. Perhaps it is the effect of the diagnosis that they had and the long-term implications of having an underlying genetic condition causing the cancer. So there are significant negative physiological factors associated with this. This is one of my patients with MEN2A634 mutation who had a bilateral pheo and medullary thyroid cancer. She had 4 other siblings, but they refused to undergo genetic testing and screening. And unfortunately, 2 of the siblings presented with locally advanced disease, medullary thyroid cancer, a few years down the line. And this could have been prevented had the patient, and the family, undertaken the genetic screening and genetic testing. What about the religious connotations? Now, we do know that there is a lot of conflict between modern medicine and religious beliefs. And a lot of times patients hold on to these beliefs very closely to the extent that they not only reject genetic testing, but also surgical and medical therapies. So one of the challenges is that if you come across a child, with an underlying genetic condition and an aggressive phenotype or aggressive cancer, how are you going to deal with this when the religious connotations come into play? Certainly we should look in the best interest of the child and provide what is necessary. But to do that, in this current situation, we need to have a strong legal framework to help protect the child. Now, there are also impacts on genetics on marriage and childbearing. And there are studies which have showed that, these religious connotations can affect mortality in children with diseases. This was again one of the patients with MEN2B. This was a young girl with severe dysmorphism. She presented with locally advanced medullary thyroid cancer invading her carotids and the laryngeal tracheal complex. You can clearly see the dysmorphism. And this unfortunate girl was not sent to school because of the way she looked. And she was even refused hospital admissions despite her advanced medical state. We did manage to cure her pheochromocytomas, but unfortunately, she passed away from the complications of medullary thyroid cancer. Now, when you look at ethical issues, of course, there are a lot of ethics concerning genetic testing. I'm not going to go into every single aspect of it, but I will talk a little bit about this thing called encounter resistance. And this is to do with insurance policies and insurance-based treatments. And you know, in many of the developing worlds and in our own parts of the world, especially in Singapore, a lot of our patients are, insurance-based treatments, and this does have an impact. Basically, if a patient has an aggressive cancer and chemotherapy is offered, at this point in time, we may not know how beneficial it may be for the patient. So we give it to all patients with a particular locally advanced cancer. We give them chemotherapy. But if supposedly there was a genetic test which could predict who would benefit from this chemotherapy, then it is likely possible that the insurance companies would ask for this predictive testing and offer payments only to patients who have tested positive. Now, this is not a very black and white sort of area when it comes to cancer management, because we do know in clinical practice, we do see patients who have a good response. We have patients who have less response. So if a patient has 50% response or less than 50% response, then are you going to deny treatment because the insurers refuse to pay for them? The other problem that we face in Singapore is how these insurers refuse payments if there is an underlying genetic disease. And this is something that is being looked into by the ministry. So it indeed is a problem. And that actually prevents patients from seeking healthcare treatments for the conditions that they face. Now, patient expectations, I did say, patients are looking forward to a more holistic approach. It's not just about managing the disease, but other aspects of patient's care as well. And this has been looked into detail, and the US and the UK, this religious and spiritual aspects of medicine is now taught as a routine in the medical schools. And this is very important because, understanding the personal beliefs when it comes to management of conditions, especially that have a genetic background, is very important. There's also an educational impact. We did say how each of the stakeholders might be affected when it comes to this precision medicine. And it's very important to have that communication between the various stakeholders for the benefit of the patients. And it's very important that these aspects be incorporated into the medical curriculum, especially pharmacogenomics. Now, I showed you a slide where how much data has been accrued over the last 2 decades in terms of genomics when it comes to the various endocrine conditions. And it's very important that we keep pace with it so that we can discuss the various implications of these with the patients. Now, of course, learning about it and teaching is one thing, but how do we interpret the complex data that is coming out on a day in, day out basis, especially variants of unknown significance or copy number and unexpected results? We do not know as senior clinicians how to deal with this and how to give that explanations to the patients. So these are things that need to be looked into the medical curriculum and possibly incorporated at the earliest possible time, because we know the future is going to be more genomics-based personalized care for our patients. So to conclude, ladies and gentlemen, today's surgeon must have an understanding of the concept of personalized medicine. Now, patients may refuse a particular treatment because of religious connotations or moral reasons, but it's about education and coming with a framework in terms of how we can help them. We have to pay more attention to holistic care, and obviously we have to incorporate this into our modern medical curriculum so that the future generation of doctors will be able to better cope with the data and communicate effectively with the patients for their own benefit. Thank you.